the $1.5 trillion private equity scam that is killing your pets and your grandparents. Why did your dog's routine checkup turn into a four-figure bill, and your grandmother's nursing home add-on fees jump overnight? Who's quietly setting those prices you never agreed to? Here's what actually happens. A handful of private equity funds now control critical pieces of care you rely on, from ER doctors to vet clinics. This isn't theoretical. It's happening in your city right now. Most people think this is efficiency. It's not. I'm going to reveal the debt-loading playbook, name the players, and show how to protect yourself. Stay for 3 payoffs: ER staffing cartels, pet care upsell machines, and the elder care squeeze, and 1 clause on your next bill that gives the game away. By the end, you'll know exactly how to spot ownership, push back, and keep money in your pocket without skipping care. How private equity actually makes money in healthcare. Okay, so here's the thing. The model isn't complicated. It's buy load with debt, cut costs, raise prices, flip fast. That's the spine. But the muscle is the incentives wrapped around it: fees, real estate, and accounting moves that make numbers look better while care gets thinner. Why healthcare? 3 reasons. First, inelastic demand. When you're hurt, you don't shop, so price hikes stick. Second, opaque pricing. You can't compare a CT scan the way you compare airline tickets. Third, insurers buffer pain. You don't feel the full cost up front, which lets providers and carriers fight over bigger numbers while you get surprise leftovers. Now the leverage lever. Private equity rarely buys with cash. They borrow against the company they're buying, so the target carries the loan. Interest payments become a monthly pressure cooker. On top of that, the fund charges management fees to the company. Then comes special dividends, cash paid out to owners by taking on even more debt. Add sale leasebacks. Sell the clinic or hospital building to a landlord they control or a REIT, then lock the operating company into rising rent. The real estate gets a steady yield. The clinic gets a new fixed cost it can't avoid. This is where the efficiency story breaks. To hit debt service and rent escalators, they need EBITDA to climb. So they game the metrics. You'll hear EBITDA add-backs, accounting adjustments that treat one-time costs as if they don't count, or add hypothetical savings that haven't materialized. On the ground, there's throughput. Shorten appointment times, raise productivity targets, and push high-margin codes. Staff-to-patient ratios creep down. Skill mix tilts toward less expensive labor. Quality measures get reframed toward what's easy to hit. Regulatory arbitrage keeps it humming. A fragmented landscape of clinics and specialty groups sits under hospital-level scrutiny. Small practice roll-ups fly below antitrust reporting thresholds. Ownership structures hide who's in charge. The result: consolidation without obvious big merger headlines. Let me show you how each piece pays. Management fees: guaranteed cash to the fund regardless of performance. Dividend recapitalizations: early payday long before real value's created. Sale-leasebacks: extract equity from real estate today, convert it to rent forever. If the business slows, that rent doesn't. So prices rise, add-ons multiply, and staffing gets trimmed to protect covenants. What gets optimized is coding and collections. The most profitable unit isn't a nurse or a vet, it's a claim. That's why you see emphasis on high-acuity codes in ERs, bundled diagnostics at vets, crowns and aligners in dentistry, and therapy thresholds in nursing homes. The playbook tunes every step to maximize reimbursable events per visit. Now about efficiency. In theory, scale lowers supply costs. In practice, those savings don't routinely flow to patients. They often get captured to service debt or fund dividends. Meanwhile, the harder-to-measure parts of care, time, judgment, continuity, are exactly what gets squeezed. There's also the exit clock. Funds aim to sell in 3 to 7 years. That timeline shapes decisions. Long-term investments that pay off in year 8 lose to short-term boosts that help this year's EBITDA. If the flip is to another fund, the cycle resets with fresh fees and debt. If it's an IPO or a carve-out, assets with reliable cash flows, like real estate or ambulatory surgery, get ring-fenced, while the riskier core gets left with obligations. You might be thinking, isn't some of this normal corporate finance? Sure, in moderation. But healthcare has special properties: captive demand, life and death stakes, and third-party payers. When you overlay high leverage, it doesn't just compress margins, it pushes clinical behavior. Scheduling algorithms prioritize revenue density over clinical complexity. Staffing budgets treat human variability like a controllable input. And when the numbers miss, the remedy isn't more time with patience. It's another round of cuts or a new revenue line, credit cards, wellness plans, optional diagnostics that somehow become mandatory. Here's a microstory that captures the incentives. Last week, a viewer sent me a vet invoice, routine limp, recommended x-ray, blood work, and a comprehensive wellness panel, bundled at a discount. The vet admitted the panel wouldn't change treatment that day. So why push it? Because bundles smooth revenue, meet monthly targets, and help service rent they didn't use to pay after a sale leaseback. Everything changes when you see the capital stack. Senior lenders want predictable cash. Mezzanine and PIK interest piles on. Covenants force adjustments when performance slips. The operators don't wake up hoping to cut corners. The debt calendar makes it inevitable. Once you understand the machine, the case studies hit harder. ER staffing groups didn't stumble into out-of-network strategies. They engineered them. Vet roll-ups aren't just branding plays. They're debt servicing engines. Nursing homes don't understaff by accident. It's how the spreadsheet balances. And dental/vision DSOs don't love upsells because they're greedy by nature. The KPI culture flows from financing demands. Keep that map in your head. Next, we're going to the ER, where surprise bills weren't a glitch. They were a business model by design. The ER takeover, surprise bills by design. Here's what actually happens when you walk into an emergency room. The hospital might be in network. The room, the bed, even the aspirin might be in network. But the doctors treating you? They could be staffed by a separate company that's out of network on purpose. That separation, hospital versus physician staffing group, was the wedge private equity used to turn your crisis into a high-margin billing event. This is not rare. Two firms, Blackstone's Team Health and KKR's Envision, at one point touched roughly a quarter of all ERs nationwide. Most people think surprise bills were random mistakes. They weren't. Consolidation created a few giant staffing firms that negotiated with insurers from a position of strength. Pay our rates or we go out of network and balance bill your members. Blackstone's Team Health and KKR's Envision became the two biggest players. They rolled up emergency physician groups nationwide, then used out-of-network leverage to demand higher payments. When insurers pushed back, the firms escalated, arbitration, litigation, and before the law changed, sending bills to patients that landed like grenades. They even funded a dark money campaign, Doctor-Patient Unity, spending tens of millions of dollars to scare Congress away from stronger surprise billing protections. Now, this is important because the choice to go out of network wasn't about clinical freedom. It was a pricing tactic. ER visits are inelastic. You can't schedule your car crash for a cheaper day. So when the company behind the doctor is ON, they can bill a much higher charge master rate, then balance bill you the gap. The threat alone often pulled insurers into paying more to keep their members from exploding on social media. Then came the No Surprises Act. It stopped most balance bills for emergency care and created an arbitration system to settle disputes between providers and insurers. Problem solved? Not quite. The law left loopholes and created a new battleground. Independent dispute resolution, where both sides submit numbers and an arbitrator picks. Guess who floods that system? Private equity-backed groups. Filing volumes spiked, costs piled up, and many cases were driven by a handful of firms. Early analyses show high provider win rates in some markets, with mass filings used as leverage. The tactic shifted from billing patients to gaming arbitration. Here's the setup payoff. When surprise billing got capped, the playbook didn't disappear. It morphed. Staffing companies leaned harder on coding intensity, pushing higher acuity codes that pay more. They tightened visit times but documented more complexity. They understaffed to cut costs, then squeezed remaining clinicians with throughput targets. The spreadsheet wins when a visit looks sicker on paper and costs less to deliver. Microstory. A viewer took their kid to an in-network ER for stitches. The hospital bill was modest. Weeks later, a 5-figure statement from a physician group nobody recognized arrived. The group wasn't the hospital. It was an LLC tied to a national staffing firm. Pre-NSA, that balance bill would have been their problem. Post-NSA, the insurer and staffing firm fought in arbitration. The family still got collection notices, while the adults argued. The lesson: the entity on the bill wasn't the hospital, it was the business model. But here's where it gets interesting. Negotiations between insurers and staffing firms resemble hostage-taking because the ER can't close. If a big staffing firm walks, the hospital scrambles to fill shifts. If the insurer refuses to pay, members suffer blowback. That structural leverage lets private equity-backed groups demand higher rates than independent physician groups ever could. And when rates stick, the extra dollars don't fund better staffing. They fund debt service and dividends upstream. You might be thinking, didn't the No Surprises Act fix patient pain? It protected many patients from direct balance bills, yes. But it didn't fix the incentives. Providers can still threaten out-of-network status to force higher in-network rates. They can file mass arbitration claims to raise the cost of resistance. And they can keep narrowing schedules, rotating temporary clinicians, and cutting support staff to meet financial targets. The harm shows up in a different column. Wait times, misdiagnoses, and as several studies suggest, worse outcomes tied to staffing reductions after private equity acquisitions. Everything changes when you look at the operational playbook. Recruit aggressively, churn physicians who push back, replace with cheaper labor where state rules allow. Use centralized billing to optimize codes. Enforce downtime caps and charting templates that nudge visits higher on the severity scale. Drop in a professional services fee on top of facility charges. If regulators tighten one screw, turn another. There's one more angle: joint ventures with hospital systems. Some staffing firms embed inside large chains, spreading their model across dozens of ERs with standardized contracts. That scale helps in arbitration, lobbying, and PR. Remember the dark money ads warning about government rate setting? Those weren't grassroots. They were funded by the very groups profiting from surprise billing, through doctor-patient Unity's ad blitz. So what's your move? First, check your explanation of benefits for a separate physician services line from a company you don't recognize. Look for emergency physician services, professional services, or an unfamiliar LLC. That's your ownership clue. Second, if you get an ER bill that feels off, call your insurer and ask specifically whether the professional component is protected under the No Surprises Act. Document everything. If collections start, file a complaint with your state insurance department and cite federal protections. If they could design surprise bills into ERs, where you legally can't shop, then vet care, where there's almost no equivalent protection, is a wide-open field. Let's go there next. Your pet as a profit center, veterinary Rollups. If they engineered surprise bills in ERs, vet care, with No Surprises Act, no insurer backstop for many visits, and lots of emotion, is target-rich. This is a market already dominated by a few giants. Mars Incorporated owns thousands of clinics. JAB Holdings NVA controls over 1,000, with VetCOR, Thrive, and regional Rollups filling in the map. Here's what actually happens when a consolidator buys your local clinic. The name on the door stays. The staff mostly stays. But the owner becomes a chain backed by a fund, and overnight the incentives shift from relationship medicine to monthly targets. Step 1 is quotas. Regional managers visit with dashboards. Diagnostics per visit, pharmacy capture rate, case acceptance percentage on dental cleanings, average transaction value. Appointments shrink from 30 minutes to 20, then 15. Vets are told to practice to standard, which means standardized protocols built to maximize reimbursable steps. More blood work panels, more imaging, more branded meds instead of generics. Price escalators kick in quietly. You'll see diagnostics bundles for routine issues, CBC, chemistry panel, thyroid urinalysis, pitched as comprehensive, even when the case is straightforward. Branded flea/tick and heartworm preventives get pushed with auto-ship enrollments. Wellness plans promise savings but lock you into monthly fees and create visit cadence the chain can forecast. Each of those lines props up EBITDA, which, remember, feeds debt service, rent from sale leasebacks, and management fees upstream. Debt isn't abstract here. Many roll-ups buy clinics with borrowed money, then sell the building to a real estate entity and lease it back with annual rent escalators. Suddenly, the clinic owes a fixed, rising rent to a landlord aligned with the investors. How do you guarantee that cash? You raise prices and increase the number of billable items per visit. That's why an X-ray that used to be "let's see if it's needed" becomes recommended, or even required before we proceed. Shortages get exploited too. There's a genuine vet workforce crunch, burnout, retirements, and fewer specialists in some regions. Consolidators leverage that scarcity. They raise prices citing market rates, Bring in locum vets at higher hourly costs but shorter shifts, and pass costs along. Wait times stretch, urgent slots vanish, and when you finally get seen, you're steered toward the high-margin path because the day's schedule is overstuffed. Here's the moment care gets compromised, the script overrules judgment. A limping dog with classic soft tissue strain might benefit from rest and NSAIDs with a watchful follow-up. The corporate protocol inserts immediate imaging, full labs, and a recheck bundled into a plan. The vet who says, "Let's wait 48 hours, gets flagged for underutilization. Repeat that across thousands of visits, and you see how targets reshape medicine. Microstory. A subscriber wrote me after a routine dental cleaning, quote, jumped from $350 to $1,100 after a buyout. The new estimate bundled pre-op blood work, 2 sets of x-rays for fluids, pain injections, branded antibiotics, and a post-op care package, plus a membership discount if they joined a wellness plan. When they asked which items were optional for a healthy middle-aged cat, the coordinator said, "Our standard of care requires them." That phrase, standard of care, has become a pricing shield. Another lever is pharmacy capture. Independent vets used to hand you a script. You'd fill it online. Chains push in-house pharmacies with manufacturer rebates and guarantees, or they'll quote extended fulfillment times for outside scripts. Some charge prescription handling fees if you insist on a third-party supplier. Margins on meds help cover rent escalators far more predictably than seasonal services. You'll also notice more care coordinators and fewer long-tenured techs. Coordinators sell plans and manage financing. Tech turnover saves on wages and keeps the mix cheaper. Meanwhile, clinics add deferred interest credit cards at checkout. Those 6-, 12-, or 18-month promos look friendly, but can backload interest if you miss a window. It's dentistry's playbook, ported to pets. Now, to be fair, some chains bring new equipment, extended hours, and access to specialists. But the savings from scale, bulk purchasing on meds, lab contracts, rarely flow to you. They're captured to service the capital stack. If the fund took a dividend recap, the pressure to extract cash intensifies. And if a chain splits real estate from operations, the rent ratchet keeps clicking regardless of local demand or seasonal downturns. How do you spot a Rollup? Subtle name tweak, new consent forms with affiliated with fine print, wellness plan pitches at check-in, and branded merch in the lobby. Ask who owns the practice and whether it's part of a larger group. Watch for scripted upsells. We recommend the gold package today. Our protocol is, it's required to proceed. Those are tells. So what's your move? Before agreeing to bundles, ask, which items change today's treatment? Request a written estimate broken out by line item, and circle anything not strictly necessary. Ask for generic meds, and if they push back, request a written prescription and compare prices through reputable pet pharmacies. If they propose a wellness plan, run the math against your pet's actual needs. Many plans front-load services you'll never use. And if you sense pressure, get a second opinion. Yes, even for pets. Here's the bottom line. When a clinic's financials are engineered around rent escalators, debt covenants, and monthly KPIs, your visit becomes a revenue operation first and medical encounter second. That's not a moral failing of your vet. It's the system wrapped around them. And if pets are being squeezed inside a lightly regulated market, imagine what happens to your grandparents in facilities paid mostly by taxpayers. That's where we're going next. Elder care under pressure, nursing homes and hospice. Now take everything we've covered and turn the dial to frail, fixed income, and out of options. That's nursing homes and hospice. Most revenue here flows from Medicare and Medicaid, which sets rates, so the way to hit investor targets isn't charging more per item. It's extracting more from the same check. That's where sale leasebacks, staffing cuts, and reimbursement games show up. Multiple national studies link private equity acquisitions to worse outcomes here, including significantly higher short-term mortality and reduced nursing hours. Here's what actually happens after a private equity buyout. Step 1. Separate the operating company from the property. The operator sells the building to a related landlord or a REIT and signs a long lease with annual rent escalators. Cash from the sale pays investors or refinances debt. But the facility now owes rising rent forever, whether census is full or not. That rent is fixed. Care becomes the variable. The lever left is staffing. Staff is the biggest line item, so hours per resident drop and the skill mix shifts. Fewer registered nurses, more aides with less training, and more temporary workers who don't know the residents. Schedules get algorithmic. Night shifts stretch thin. Call bells wait. On paper, staffing meets minimums. On the floor, people fall, infections spread, and small problems snowball because there's no one to catch them early. You'll hear operational improvements. Look at the incentives. Rent ratchets up, debt service is due, management fees come out. So the facility needs margin from somewhere. That's where reimbursement gaming comes in. In skilled nursing, Medicare therapy thresholds used to drive minutes of PT and OT right up to the cusp that paid best, regardless of patient benefit. When policies changed, the focus moved to coding acuity and length of stay optimization. In hospice, the math is different but familiar. Per diem payments make longer stays profitable, especially in routine home care. So eligibility edges widen, and discharges get messy when prognosis improves. Liability shields add another layer. Ownership is sliced into LLCs. PropCo owns the buildings, OpCo runs the beds, a management company holds the contracts, and a payroll company employs staff. When families sue over negligence, they confront a maze. Even if they win, the operating shell might be thinly capitalized. Meanwhile, the property company keeps collecting rent. Let me ground this with a micro-story. A viewer's father in a PE-backed facility fell twice in 1 week. The first time, his bed alarm wasn't connected after a sheet change. The second time, his toileting schedule was deferred during a shift change. He fractured a hip and never fully recovered. The administrator blamed unprecedented staffing shortages. But internal emails shared later showed a rent step-up hit that quarter and a directive to reduce overtime by 20%. The fall wasn't an accident. It was a balance sheet decision arriving at the bedside. You might be thinking, isn't hospice the humane alternative? It is when mission drives care. Under investor pressure, the model can twist. Enrollment can skew toward patients with longer, more predictable courses because revenue is steadier. Visit frequencies trend down. Social work and chaplain hours get trimmed first because they don't move the needle. Families report more phone calls, fewer in-person visits, and last-minute equipment delays because inventories were centralized to save costs. Everything changes when you ask, who owns the facility and who owns the land? If the landlord is a related entity, rising rent acts like a siphon. Operating budgets shrink even when public payments stay level. That's why you'll hear about new efficiencies while seeing fewer CNAs on the floor. It's not just bad management, it's the math. So what do families actually face? An impossible triangle: availability, quality, and cost. The nearby facility with open beds is often the one that maximizes throughput. The nonprofit with strong staffing has a wait list. And moving a loved one is traumatic and risky. Families accept what's available and try to fill gaps with their own labor, hiring private aides or sleeping in chairs to watch for pressure sores. That's unpaid work replacing paid care to sustain a financial structure. Here's how to push back intelligently. For nursing homes, ask for the most recent staffing hours per resident day, broken out by RN, LPN, and CNA. Don't settle for averages. Request the distribution by shift. Check state inspection reports and federal quality ratings, but look specifically at staffing and health deficiencies, not the composite score. Ask directly, is the facility operated by a company different from the property owner? Who's the landlord, and what are the rent escalators? If they dodge, that's a signal. On hospice, ask about interdisciplinary visit frequency and how often an RN will visit in the last week of life. Clarify after-hours response times and whether they staff for continuous care when symptoms spike. If the answers are vague, consider another provider, even if it means a tougher start. There's one more pattern: turnover. After a buyout, administrators churn, directors of nursing leave, and temp agencies fill gaps. Continuity dies, and with it, the tiny details that keep residents safe. How Mrs. J favors her left side, how Mr. K decompensates when rushed. Every departure is a leak in the care system. I want to be fair. Some investors do fix roofs, replace boilers, and digitize meds administration. But the dominant outcome under heavy leverage is not reinvestment, it's extraction. And the data lining up on higher mortality and adverse events after acquisitions should end the debate over whether this pressure is visible in outcomes. It is. If pets felt the squeeze in a lightly regulated market, elder care shows what happens when public money and private extraction meet. Dentistry and vision will show the pure consumer upsell engine. Let's go there next. The dental and vision upsell machine. Dentistry and vision care are where the upsell engine is right in your face. Most people think, it's my dentist, it's my optometrist, they're just recommending what I need. You need to know this. Private equity-backed DSOs and optical chains have turned chair time into quota time, and the math shows up in your mouth and your glasses. Most of the largest DSOs are private equity-owned, and past enforcement actions have exposed overtreatment schemes in chain settings. Here's how the DSO model works. A central company takes over billing, marketing, call centers, HR, and vendor contracts. On paper, that frees clinicians to focus on care. In practice, it centralizes power around KPIs. Chair utilization per day, case acceptance rate, production per hygienist, whitening and aligner conversion, crown per visit ratios. Schedules compress to 45-minute hygiene blocks with a handoff to the dentist for a doctor exam and treatment presentation. Standardized pathways push high-margin procedures, full mouth x-rays, perioscaling, crowns over large fillings, root canals and posts, same-day aligners. Now, this is important because financing is the fuel. You'll see easy payment plans, zero down, and deferred interest medical credit cards. The rate looks like percent for 12 months, but miss a deadline and retroactive interest hits at 25% APR. Some offices bundle membership plans, annual fees for 2 cleanings and a discount tier, which quietly raise case acceptance because the discount is anchored to inflated list prices. The result is predictable: higher production per patient, more debt carried by consumers, and EBITDA that looks great in a lender's deck. Procedure inflation is the heart of it. Most people think a crown or an aligner is always the better option, but many DSOs set thresholds that favor aggressive treatment. If a filling crosses X millimeters, crown it. If crowding is mild, pitch aligners with whitening and retainers. If there's any bleeding on probing, drop into periodontal maintenance with multiple follow-ups. Add-ons creep. Electric pulp testing, intraoral photos billed separately, desensitizing varnish, laser adjuncts. Each code stacks. Each minute is optimized. And then there's the KPI culture. Case acceptance rate becomes a leaderboard item. Clinicians get dashboards and coaching. Conversations shift from "here are options" to "here's your treatment plan. Let's book it today." Some offices script the handoff. Hygienist pre-frames urgency, dentist confirms, treatment coordinator closes with financing. If a dentist advises a conservative approach, a clinical director may review their numbers and label them underdiagnosing. Over time, judgment bends to targets. Vision care mirrors the pattern. Chains own exam lanes in retail. Exams are short, tech-heavy, and geared to throughput. The real money is in frames, lenses, coatings, and subscriptions. You'll be steered to premium lens packages. High-index material, blue light filters, anti-fatigue coatings, scratch resistance, UV layers, bundled at a value price. Contact lens fitting fees rise, annual supplies get auto-shipped, and rebates lock you into brand families tied to vendor contracts. Out-of-network benefits are framed as paperwork pain to keep you captive. Here's a quick micro-story. A viewer went in for a routine cleaning. The hygienist recommended deep cleaning for generalized mild gingivitis. The treatment plan ballooned: quadrant scaling, antibiotic chips, 3-month recalls, laser therapy. Total, over $1,800, financed at the desk. When they asked for evidence, pockets, bone loss, bleeding map, the coordinator repeated, "It's the standard of care." Another opinion at an independent office: regular cleaning, floss coaching, $160 out the door. That gap is the KPI talking. Everything changes when you follow the debt math. DSOs carry acquisition debt, pay management fees, and often execute sale leasebacks on flagship locations. Rent escalates annually. To keep covenants, they need predictable production. That's why they standardize diagnosis pathways and push financing. Variability is the enemy of debt service. A similar story plays in optical. Parent companies sign vendor minimums with lens labs and frame conglomerates. Stores must hit mixed targets, so basic becomes scarce and premium becomes default. You might be thinking, are there benefits to scale? Sure, central sterilization protocols, better IT, faster lab turnarounds, extended hours, sometimes lower supply costs. But the savings rarely drop to you because they're captured upstream to service the capital stack. Meanwhile, time, arguably the most therapeutic element, gets cut. Fewer minutes per exam means more template-driven treatment and less individualized decision-making. So how do you protect yourself without skipping care? 5 simple moves. 1. Ask for a written treatment plan with CDT codes and tooth numbers. 2. Ask the dentist to mark which items are urgent, which are preventive, and which are elective. 3. Get radiographs on a secure link and seek a second opinion at an independent office. 4. Compare financing options. Credit union personal loan versus in-office deferred interest. Never sign without reading the penalty clause. 5. In optical, ask for your full prescription, PD, and lens parameters. You're entitled to shop lenses, not just frames. Watch for tells. In dentistry, production goals posted in staff areas, rotating providers, heavy emphasis on whitening, aligners, and crowns, and a coordinator who appears before the dentist finishes speaking. In vision, good, better, best lens boards with the good tier out of stock, pushy annual supply pitches, and a refusal to give pupillary distance. These aren't random, they're system design. One last thing. Ethical dentists and optometrists work inside DSOs and chains. Many hate the pressure and still advocate for you. If you find one, support them, book with them, decline what you don't need, and leave reviews that praise conservative, transparent care. That signals to management that trust builds lifetime value better than aggressive short-term production. Follow the money, debt, fees, and exit games. Let's pull back the curtain on the capital stack, because this is where the incentives harden. Start at the top, senior lenders. They want predictable cash every month, so they write covenants, minimum EBITDA, leverage ratios, interest coverage. Miss a covenant and lenders can force changes. Sell assets, cut costs, raise prices. Below them sits mezzanine debt, often with higher interest and looser collateral. Sometimes there's PIK interest, payment in kind, where interest gets added to the loan instead of paid in cash, inflating the balance like a snowball rolling downhill. Equity sits last, but collects fees along the way. If you want a case study of extraction before collapse, look at Kano Health, loaded with debt, management fees, and dividends before heading into bankruptcy. Now, how do owners get paid early? Dividend recapitalizations. After they buy a chain, they borrow more against improved EBITDA, then pay themselves a special dividend. No new value created for patients, just more leverage on the operating company. Layer on management fees, 3% of revenue here, a monitoring fee there, and you've got cash streaming to the fund regardless of whether outcomes improve. If performance stalls, the fees keep going. The clinic has to find the money. Then there's the real estate split, OpCo/PropCo. The operator sells the building to a related or friendly landlord, pockets cash, and signs a long-term lease with annual escalators. On day 1, investors celebrate unlocked value. On day 2, the operating company has a new fixed cost that only moves up. In healthcare, where revenue isn't perfectly controllable, rising rent becomes a ratchet. Operators respond the only way they can: trim staffing, push higher margin services, and raise list prices. Meanwhile, the PropCo pays out steady dividends to investors, insulated from clinical volatility. This is important because it explains why efficiency claims often mask value extraction. Yes, scale can lower supply costs, but those savings are frequently earmarked to cover interest, fees, and rent long before any patient sees a discount. Look at the cash waterfall. Revenue comes in, payroll and supplies go out, and then debt service, rent, and fees take their cut. Whatever's left competes with reinvestment, training, staffing, time per patient. When the waterfall runs low, it's not the lease that flexes. It's the schedule and the care plan. You might be thinking, how do they keep the story optimistic for lenders? EBITDA add-backs show up again. Normalized staffing, one-time integration costs, anticipated synergies. In a lender deck, those numbers justify more borrowing. In practice, they justify more pressure. If the add-backs don't materialize, operators are told to realize the plan. Code for pushing harder on coding, throughput, and headcount. That's when algorithms start dictating appointment lengths and leaders start right-sizing teams. Let's talk exits. There are 4 main paths. 1. Strategic sale to a larger health system or consolidator. The buyer wants network effects, payer leverage, and synergies. Read, lower combined staffing and better vendor terms. 2. Sell to another private equity fund. Fresh fees, fresh debt, same playbook. The clinic changes logos, the spreadsheet stays. 3. IPO or partial carve-out. Profitable pieces, ambulatory surgery centers, imaging specialty lines, get packaged as growth stories, while slower, labor-heavy operations remain in the private entity with most of the obligations. For bankruptcy. In that case, investors try to ring-fence valuable assets, landlords keep collecting, and communities face closures or service cuts. Notice who has hedges. Investors diversify across funds and sectors. Lenders have collateral, landlords hold leases. Patients and local workers don't have hedges. When the math fails, the ER closes overnight, the vet clinic slashes hours, the nursing home trims staff again, and the DSO consolidates locations to optimize the footprint. There's also the related party web. A management company bills the operator for services. A lab relationship steers tests to a favored vendor with volume rebates. A supply distributor under the same umbrella secures minimum purchase commitments. Each related party extracts a margin. On paper, the operator's EBITDA looks healthy, because some of the profit moved upstream before anyone counts care. Follow the money, and you'll see it routed around the bedside. Regulators are starting to probe these structures, but disclosures are still thin and delayed. Here's a quick microstory. A Midwestern surgery center group did a dividend recap 2 years after a buyout. The owners took cash. The OpCo took on rent after selling its flagship buildings to an affiliated REIT. When volume dipped for 6 months, flu season cancellations and a payer dispute, the lenders pushed for expense rationalization. The center cut pre-op nurses and extended PACU ratios. Cases still cleared, but turnover slowed, cancellations rose, and surgeons left for hospitals with better support. The numbers met covenants, the care degraded, the franchise value eroded. That's the silent cost of financial engineering. Everything changes when you accept that debt shapes clinical behavior. It's not just a line on a balance sheet. It's the invisible hand in every upsell, every shortened visit, every protocol that sounds medical but reads like margin management. Investors will say the discipline of capital improves operations. Sometimes discipline helps. But when the priority is extracting cash fast, the system trains people to treat problems as revenue opportunities and time as waste. So the next time you see a glossy claim about quality at scale, ask 3 questions. Who owns the real estate? What fees flow to related parties? And did the owners pull a dividend since they bought this place? Those answers tell you more about your future care than any press release will. The regulatory maze and the loophole economy. So if the incentives are this strong, why don't rules stop it? Because the rules were built for a different era. Certificate of Need laws, state licensure boards, and hospital regulators focus on large facilities and headline mergers. Meanwhile, private equity thrives in the shadows, serially buying small practices, slicing ownership into shells, and staying under reporting thresholds. Enforcement is catching up. Federal agencies in several states have announced new focus on roll-ups and corporate practice violations, but the gap remains wide. Start with antitrust. Most people think big mergers trigger review and blockades. Roll-ups avoid that. They buy dozens of small clinics, each deal under federal Hart-Scott-Rodino reporting limits, until one day a region has 3 choices instead of 30. On paper, no single transaction looked scary. In reality, patients face a local monopoly with market rates. Regulators are catching on, but the backlog is real, and the statutes weren't designed for drip-by-drip consolidation. Expect more cumulative review from the FTC and state AGs, but don't expect it to arrive in time to save every market. Now, Certificate of Need. In some states, you can't open or expand certain facilities without proving community need. Sounds protective, but incumbents weaponize it. Large systems and roll-ups contest competitors' applications, delaying entrants who'd offer alternatives. The result is fewer independent options and more leverage for the consolidated players who already got through the gate. Ownership disclosure is another blind spot. Many states require listing a medical director or a professional corporation as the owner to comply with corporate practice bans, but the economic control sits upstream in management services agreements. The public file says Dr. Smith, PC. The cash flows show a private equity fund setting budgets, metrics, and payments. Patients and even staff may not know who's calling the shots until policies change and prices jump. Surprise billing rules closed one door and opened another. The No Surprises Act removed most balance bills for emergencies, but it birthed a complex arbitration process with timelines, batching limits, and fees. Large staffing firms with legal teams can flood the system, file thousands of disputes, and grind payers down. Small practices won't. That asymmetry becomes a negotiating weapon. The law protected many patients, but it didn't neutralize the leverage of scale in post-NSA battles, and early data show high provider win rates in some states driven by repeat corporate filers. Accreditation provides optics, but not always teeth. You'll see gold seals and centers of excellence. Those programs focus on documentation, protocols, and periodic surveys. Smart operators staff up for inspection week, clean the dashboards, and revert after. Meanwhile, the metrics that matter, actual staff-to-patient hours, continuity, outcomes beyond the narrow window, aren't consistently public or enforced. It's quality theater that satisfies purchasers without guaranteeing bedside reality. Real estate is a regulatory gray lane. Sale-leasebacks and OpCo/PropCo splits rarely trigger healthcare-specific review. Landlord-tenant terms, rent escalators, cross-defaults, remedies, effectively govern clinical budgets for years, but they live in private contracts. A facility can meet every clinical rule while being strangled by rent it has to pay to a related entity. When closures happen, it's market conditions, not a licensure issue. Insurance rules create another loophole economy. Prior authorization and narrow networks were meant to control costs. Consolidators turn them into bargaining chips. Approve our codes, or we'll take 200 physicians out of network at once. For pets, there's even less guardrail. Vet insurance is lightly regulated. Wellness plans are prepayment contracts, and financing products skate between banking and healthcare oversight. If a provider pushes a deferred interest card, that's a consumer finance problem, not a medical board problem, until both collide in a lobby. Secrecy compounds everything. Private equity-owned entities aren't subject to the same continuous disclosures as public companies. Financials are aggregated, affiliates are nested, and related party deals live in footnotes, if anywhere. By the time journalists or state AGs trace ownership, the assets have moved, leases have been reassigned, and brand names have changed. The game is speed and opacity. Regulators are built for deliberation and sunlight. So who's winning the arbitration fights and loophole runs? The pattern is clear: groups with capital, data, and repetition. They can litigate, arbitrate, and iterate. They learn which codes slide through, which markets resist, which boards are slow. Every denial becomes training data. Independent clinicians can't play that volume game. They're too busy treating patients. Now, this is important because when rules lag, communities and workers become the backstop. Nurses unionize for staffing ratios where states won't set them. Local coalitions demand ownership transparency at the county level. Employers contract directly with centers that publish outcomes and prices. Vets form co-ops to pool purchasing and keep clinics independent. These aren't perfect, but they're adaptive responses to a loophole economy. And policy wins are possible. One state recently passed the toughest limits on corporate control of medical practices, showing the door isn't closed. Microstory: a mid-sized city saw its last independent ER physician group get bought. Within months, patient complaints spiked. The county health board had no authority over staffing contracts, but the hospital's nonprofit status required community benefit reporting. A coalition pushed for a memorandum linking tax exemptions to minimum clinician coverage by hour. The hospital complied to keep peace. No law changed, leverage did, because the community understood where the formal rules ended and informal pressure began. Everything changes when we stop assuming regulation equals protection. It often equals a baseline. The system's most powerful actors design around it. Until disclosure is real, serial acquisitions aggregate, and sale-leasebacks face scrutiny, the loophole economy will keep extracting. That's why organized workers, informed patients, and local oversight often move faster than federal fixes. We'll get to those levers next, because outrage without a playbook just feeds burnout. If you know where the gaps are, you can close them locally and support smarter policy that scales. The human cost: workers on the front lines. If patients feel the squeeze, workers live inside it every shift. Here's what actually happens on the floor when the spreadsheet takes over. Staffing gets cut, skill mix slides down, and the clock becomes the loudest voice in the room. Nurses go from 4 patients to 5, then 6. Aides cover 2 hallways. A tech floats between units they've never seen. On paper, staffing meets targets. At the bedside, alarms stack, documentation lags, and small problems get missed until they're crises. After private equity acquisitions, physician turnover in some specialties has been measured at multiples higher than peers, and clinician satisfaction scores crater compared to physician-led groups. Scheduling algorithms promise efficiency and deliver chaos. They fill slots by averages, not acuity. A night with 3 high-acuity admits and a fresh post-op gets the same staffing as a calm census because the model wasn't built for uncertainty. So clinicians backfill with unpaid time, charting off the clock, calling families on breaks, cleaning rooms when housekeeping is thin. The burnout isn't abstract. It's the mismatch between what they know patients need and what the shift allows. Now, this is important because the culture flips when debt-driven targets arrive. Leaders stop asking, what helps care? And start asking, what hits metrics? Throughput replaces recovery time. Left without being seen becomes a dashboard obsession, so triage rushes and hallway beds multiply. ICU nurses get cross-trained to cover step-down without support. In clinics, medical assistants are stacked 2 to 1 with a physician to drive volume. But turnover means constant retraining and more errors. Whistleblowers face a classic dilemma. Speak up about unsafe ratios or billing pressure, and retaliation can be subtle. Undesirable shifts, canceled PTO, performance plans. HR frames it as fit. Meanwhile, the message travels. Keep your head down. Some clinicians try quiet resistance, refusing unnecessary tests, insisting on longer visits for complex patients. But the KPI reports flag them as outliers. Over time, people who care most about standards either bend or leave. Let me give you a microstory that came in last month. A respiratory therapist wrote that after a PE acquisition, night coverage dropped from 2 RTs to 1 for a large med-SURG floor. When a code blue hit as multiple new admits arrived from the ED, the RT bounced between rooms, leaving a fresh COPD admit on minimal monitoring. The patient decompensated, avoidably. Management called it a systems issue. The RT called it what it was, predictable, because the coverage model assumed no spikes. Wage dynamics add insult to injury. Corporate decks celebrate operational improvements, yet wages stagnate or get replaced by one-time retention bonuses tied to signing non-disparagement clauses. Travelers cost more than staff, but leadership leans on them because they're flexible for the spreadsheet, even if continuity and morale crater. Physicians feel it too. Autonomy shrinks, productivity RVUs rise, and care pathways become mandates built around billing, not nuance. Everything changes when turnover spikes. New grads cycle in, mentors cycle out, and institutional memory vanishes. A unit that once ran on unspoken coordination becomes a set of strangers following checklists. Checklists matter, but they don't replace knowing Mrs. G stands before she sits, or that Mr. L needs extra cues to swallow safely. That tacit knowledge is the first thing lost when a service line becomes a financial product. You might be thinking, can't unions and professional standards push back? Sometimes, yes. Nurse-to-patient ratio laws help where they exist. Contract language can limit mandatory overtime and protect whistleblowers. But corporate structures adapt, outsourcing units to affiliates, reclassifying roles, or leaning on per diem pools that fall outside agreements. Without transparency on ownership and debt, workers negotiate in the dark against entities designed to be hard to pin down. So what keeps people going? Professional pride in each other. Teams create informal safety nets. Buddy systems for turns, text trees for surge shifts, shadow charts that track high-risk patients beyond the EHR's boxes. They swap scripts for pushing back on unnecessary add-ons, clinically not indicated today. They document deviations to build a record when outcomes slip. Here's the candid truth. When care is governed by rent escalators and leverage ratios, every shift asks clinicians to trade off between what's right and what fits. That moral distress is the engine of burnout. If we want safer care, we don't just need pizza parties. We need staffing floors tied to acuity, real-time ownership disclosure, and protection for the people who say no when the metric is wrong. Because when the workers break, patients pay next. Spotting PE control in your care. Once you know the patterns, you can spot them fast. Start with the paperwork. Bills, consent forms, and appointment reminders often list an unfamiliar LLC, affiliated with, or managed by another entity. That phrasing is your first breadcrumb. The storefront name might be Main Street Clinic, but the biller is Main Street Physician Services, PLLC, and the fine print says management by a national group. That's a control flag. Next, watch for brand-neutral rebrands. A subtle name tweak, new logo color, and suddenly standardized forms rollout system-wide. You'll see unified fonts, consent checkboxes covering data use, arbitration clauses, and cross-referral language to sister facilities. Ask for a copy of any financial responsibility or dispute resolution clause before you sign. Forced arbitration is common. It's not clinical, it's corporate risk management. Financing offers are another tell. Aggressive pushes for zero-interest cards, third-party payment plans, or wellness memberships mean the business model depends on smoothing revenue. In medical, that's care credit-style cards. In dental and vet, it's membership plans with auto-pay and exclusive pricing. If checkout sounds like retail, assume investor pressure upstream. Time is data. Appointment slots that shrink abruptly. 20 minutes to 12, 12 to 10, signal throughput targets. Pair that with scripted upsells. You'll hear identical phrasing across locations. Our protocol recommends. The standard package includes, to proceed we require. When a recommendation sounds like a sales script, it probably is. Staff churn tells a story. Ask how long your primary clinician, nurse manager, or vet has been there. Frequent turnover plus more care coordinators and fewer seasoned techs suggests a shift towards sales roles over clinical continuity. If you can't book the same clinician twice, that's productivity management, not patient-centered scheduling. Property separation leaves a paper trail. Look for a rent line in nonprofit financials, public hospital board packets, or disclosure forms. If operating losses grow while rent rises to a related landlord, you're looking at an OpCo/PropCo split. For physician offices, clues show up in county property records. A sale to an LLC, followed by a long lease recorded with annual escalators. Patients won't see the lease, but price hikes and add-ons will reflect it. Insurance battles as tactic, not accident, are recognizable. Entire service lines suddenly go out of network while negotiations continue. You'll get notices framing the payer as unreasonable. If multiple specialties tied to one management company flip at once, that's coordinated leverage. Track the contracting entity names on your EOBs. If they match across different clinics, you've found the consolidator. Digital breadcrumbs help. Search the practice name plus Management Services Organization or Partner. Check state corporate registries for officers' names. If the same executives appear across dozens of entities, you've mapped a roll-up. National provider directories sometimes reveal the parent brand hidden behind local websites. LinkedIn is useful. Look up your clinic. If many staff list the same parent company, that's confirmation. On the ground, ask 5 questions at check-in. 1. Who owns this practice and who manages non-clinical operations? 2. Is this facility or its physicians part of a larger group? 3. Are there any financial relationships with labs, imaging, or pharmacies you might refer me to? 4. If I decline a bundle, what changes in today's care plan? 5. If there's a dispute, how is it resolved? Public court or arbitration? Document answers. Evasiveness is data. For elder care, add 3 more. Who owns the building? What are the current staffing hours per resident day by role? What was staff turnover last quarter? For hospice, ask visit frequencies by discipline and escalation protocols for crisis care. Specifics matter. Generalities hide capacity shortfalls. For pets, listen for brand names behind the counter. If the receptionist mentions a national HR portal, centralized scheduling, or corporate policy, you're in a network. Ask for a written estimate with each line labeled necessary, recommended, or elective. If required, appears often without clinical rationale. It's a quota culture. What if you confirm PE control? Don't panic. Use it. Request itemized estimates in writing. Ask for generics. Leverage insurance protections in ER settings. Seek second opinions at independent clinics. Many publish ownership proudly. Compare nonprofit and public options for elder care. And organize intelligence locally, neighbors' experiences, staffing stability, owner transparency. When you can see the ownership web, you can shop smarter, negotiate harder, and escalate faster. Protect yourself, practical patient and family tactics. Let's turn outrage into a playbook. First move, ask up front and get it in. Writing. Before non-urgent care, say, Who owns this practice and who manages non-clinical operations? Are there related party landlords? Ask, are the clinicians and the facility in network for my plan? Request a written good faith estimate with CPT/CDT codes, line items marked necessary versus elective, and any financing terms. If they hedge, note it on your phone and email the office for confirmation. Paper trails change outcomes. Next, use tools that actually surface prices and ownership. For hospitals, check the CMS hospital price transparency files or third-party scrapers that turn those CSVs into usable numbers. Compare cash pay, in-network, and out-of-network rates. For imaging and labs, independent centers often publish transparent cash prices. Call 3 and ask for the CPT code price. For physicians, many states have corporate registries and medical board lookups that reveal who controls the entity. Nonprofit directories and watchdog sites sometimes map rollups. Cross-check the biller name on your EOB. When the bill hits, negotiate like a pro. Step 1. Ask for an itemized bill and the UB04 or CMS 150 claim form. Step 2. Request a coding audit. Politely flag upcoded levels or duplicate charges. Use specific language. Please rebill with CPT 99283, not 99285, based on the documentation. Step 3. Ask for prompt pay discounts in writing. Many providers will shave 10 to 40% off for payment within 10 to 30 days. If insurance denied something, appeal immediately. Escalate to a supervisor, then your plan's external review. Keep a log, dates, names, reference numbers. If you're stuck between insurer and provider, leverage regulators. File a complaint with your state insurance department referencing the No Surprises Act for ER professional charges. Use your state's Attorney General Consumer Protection Portal if the provider pushes deferred interest financing without clear disclosure. For Medicare issues, contact your state Health Insurance Assistance Program, SHIP. Persistence wins. Each complaint forces a paper response and pauses collections. For elder care, walk in with a checklist. Ask for hours per resident day by role for each shift, not a weekly average. Request the last 3 state inspection reports and the corrective action plans. Ask, who owns the building and what are the rent escalators? Meet the director of nursing and ask about turnover for CNAs, RNs, and administrators over the past 12 months. Call the long-term care ombudsman and ask what families have reported recently. Visit at off hours, late evening or Sunday morning, to see real staffing. When touring facilities, test the system. Ring a call bell and time the response. Check for pressure relief cushions, bed alarms with cords actually attached, and hydration stations. Ask to see the wound care log and the staffing assignment sheet. If they claim HIPAA to block basic process questions, that's a red flag about transparency, not privacy. For hospice, pin down visit frequency by discipline and surge capacity. Ask, how often will an RN visit in the final week? What's your after-hours response time? Do you provide continuous care at home for uncontrolled symptoms? And how quickly can you staff it? Clarify what equipment is included and delivery timelines. If answers are vague, keep shopping. For pets, pre-commit to a plan. Before elective procedures, ask for a written estimate with each line labeled necessary, recommended, or elective. Request generics and a written prescription to price check online. If they push a wellness plan, map the services against your pet's needs over 12 months. Decline auto-renew and deferred interest. For emergencies, keep a short list of independent clinics and 24/7 hospitals with transparent triage fees. 2 universal tactics. 1. Second opinions save money and protect care. Bring your images and labs on a digital copy, not just a summary. 2. Script your no. Say, if declining this item changes today's treatment or safety, tell me specifically how. Otherwise, I'd like to wait. That forces clinical justification over sales language. Finally, organize locally. Share ownership intel, good clinicians, transparent facilities, and fair cash prices in neighborhood groups. Create a simple spreadsheet, owner, landlord, if known, staffing stability, and billing behavior. When communities trade notes, patterns surface, and leverage shifts. Community and policy levers that actually move. Individual tactics matter, but systems change when communities pull the right levers. Let's start with the simplest, most powerful fix, staffing floors. Where states set minimum nurse-to-patient ratios tied to acuity, outcomes improve, and the incentive to understaff weakens. If your state won't legislate it, push hospitals and nursing homes to adopt ratio commitments as part of nonprofit community benefit agreements or certificate of need approvals. Tie tax exemptions to transparent, audited staffing hours by shift. Point 2. Recent state reforms curbing corporate control of medical practices to show it's politically possible. Ownership and debt transparency is next. Require facilities to disclose ultimate beneficial owners, related party landlords, sale-leaseback terms, and dividend recapitalizations in plain English, updated annually. Cities can condition permits and subsidies on these disclosures. States can mandate public filings with searchable databases. When landlords and management companies share a parent, rent ratchets become visible and negotiable. Close the roll-up loophole with cumulative antitrust review. Instead of judging deals one by one under reporting thresholds, assess market share over rolling windows in defined geographies. States don't need to wait for federal change. Attorneys general can issue guidance treating serial acquisitions as a single transaction for scrutiny. Hospital boards and health commissions can add no net loss of independent providers clauses to local approvals. Shine a light on sale-leasebacks and related party deals. Require healthcare operators to file leases with regulators, including rent escalators, cross-defaults, and remedies. Force disclosure of any overlap between landlord and operator ownership. If a nonprofit spins off real estate, demand a community use covenant so rent hikes can't force closures without a public hearing. Strengthen surprise billing enforcement and arbitration fairness. Cap batching fees to prevent weaponized mass filings. Speed timelines for emergency claims, and publish provider win rates by entity so payers and regulators spot abuse. Create a small practice fast lane so independents can access the process without being drowned out by corporate volume. Support federal and state efforts to scrutinize serial roll-ups so markets can't be cornered quietly. Protect workers who protect patients. Pass safe harbor whistleblower laws with anti-retaliation teeth and presumptive reinstatement. Fund unit-based staffing committees with binding authority over ratios and float policies. Ban non-disparagement clauses tied to retention, bonuses in healthcare settings. The public needs to hear when corners are being cut. Support public and nonprofit alternatives. City and county funds can seed urgent care centers attached to public hospitals, expand community dental clinics, and subsidize nonprofit veterinary care in high-need areas. Employers can contract directly with transparent centers of excellence and steer members using shared savings plans. Every dollar moved to mission-driven providers pressures extractive models. Modernize payment to reward outcomes in time, not just throughput. For primary care, expand enhanced capitation with guardrails, transparent panel sizes, access standards, and mandatory reinvestment in team-based staffing. For dental and vision in public plans, tie reimbursements to necessity documentation and second opinion access, not volume of procedures. Regulate patient financing like medical care, not retail. Ban deferred interest medical credit and require plain language cost disclosures before any financing is offered. Mandate cooling off periods for elective dental bundles and high-cost optical packages with easy cancellation. If an office pushes credit without a medical necessity statement, that's a violation. Create state-level healthcare transaction registries. Any acquisition of a clinic, staffing group, or facility above a modest threshold files a notice with ownership details, debt added, fees paid, and any real estate transfer. Publish it. Pair that with data on prices, denials, arbitration outcomes, and staffing. Transparency isn't a press release, it's a living ledger. Boost local leverage with simple tools. Counties can require hospitals to report monthly ED coverage hours, boarding times, and clinician vacancy rates as a condition of property tax abatements. School districts and municipalities, as major purchasers, can require network providers to certify no related party rent increases above CPI without disclosure. Public pension funds can use their capital to set expectations for private equity managers. No dividend recaps until quality and access targets are met. Clawbacks for avoidable closures. Finally, build coalitions that move fast. Pair nurses, independent clinicians, patient advocates, and employers. File coordinated comments on roll-ups. Show up at hospital board meetings with staffing data. Launch community price and ownership maps so people can choose with their feet. Investors argue consolidation saves care. Let's stress test that claim next and bring receipts. The case for and against consolidation with receipts. Let's stress test the claim. Consolidation fixes broken care. The pro case sounds tidy. Scale should lower supply costs, centralize admin, standardize protocols, expand hours, and recruit talent to underserved areas. Larger networks can negotiate better lab rates, share expensive equipment, and build specialty coverage a solo clinic can't. In theory, that means safer care at lower prices with more access. In practice, when consolidation is paired with high leverage and early cash-outs, the pressure lands on staffing and prices. Now the receipts. Purchasing power is real, but pass-through to patients is rare. When systems get lower prices on implants, lenses, drugs, or lab panels, savings usually flow first to cover debt service, management fees, and rent, not to cut your bill. Price transparency files routinely show system-owned outpatient departments charging multiples of independent centers for identical CPT codes after facility fee layering. That's scale monetized, not shared. Standardized quality can help for true high-reliability tasks. Central line bundles, surgical checklists, sepsis pathways. But templates drift into revenue design. We've seen standardized care pathways double as procedure playbooks. Crowns over large fillings, deep cleanings for borderline gum scores, high acuity ER coding when chart templates prompt boxes that tip the level. Consistency becomes a billing engine when finance sets the lanes. What about outcomes? Evidence keeps cutting through the rhetoric. Studies link private equity acquisitions to staffing cuts and higher adverse events in hospitals, and roughly 10% higher mortality in nursing homes compared to non-PE peers. ERs at PE-acquired hospitals saw ED deaths rise alongside salary and staff reductions. Those aren't abstract metrics. They're the predictable result of shrinking labor to hit leverage targets. Access and stability are mixed at best. Consolidation can reopen a closed service line or fund a new MRI until rates slip or covenants bite. Then sites close, hours shrink, and communities absorb the fallout. Bankruptcy stories in hospital chains and staffing firms show the same pattern. Landlords and lenders protect their position while patients lose options. That's not resilience. That's fragility dressed as scale. To be fair, where does consolidation help? Trauma centers and comprehensive stroke networks need volume and coordination. Rare specialty programs, pediatric cardiac surgery, complex oncology, benefit from centralized teams and shared protocols. Supply chain during crises can be smoother in large systems that pre-purchase and stockpile. And tech investments, EHR integration, antimicrobial stewardship, radiation dose monitoring, are easier to fund at size. Those wins are real when governance is mission-driven and leverage is capped. So why does the promise so often fail? Governance and debt. If the board prioritizes clinical investment and time per patient, scale's advantages show up at the bedside. If the balance sheet is loaded and owners pull early dividends, the math forces shortcuts. Add opacity, related party landlords, management fees, asset splits, and even well-meaning leaders are boxed into extracting more from each encounter. Let's put the investor claim under the lamp. We professionalize small, inefficient practices. Sometimes that means real back-office cleanup. Often it means turning clinician time into quota time. Hiring pipelines become replacement pipelines as burnout meets KPI dashboards. Staff replacement ratios jump, turnover rises, continuity collapses. Any gains from centralized purchasing evaporate when you swap experienced teams for churn. A practical line in the sand emerges. Consolidation aligned with care, low leverage, transparent ownership, quality-linked reinvestment can scale what works in trauma, rare disease, and genuine back-office efficiency. Consolidation aligned with extraction. High leverage, sale leasebacks, dividend recaps, procedural quotas, erodes trust, inflates prices, and degrades outcomes. The difference isn't the logo size, it's the capital structure and who captures the surplus. Most people think the choice is binary, fragmented chaos or corporate order. It isn't. You can have organized networks without predatory finance. Physician and nurse-led groups can pool purchasing and data without loading debt. Public and nonprofit systems can standardize where evidence is strong and leave clinical judgment where nuance matters. That's not anti-scale, it's anti-extraction. Here's the simple test you can use and policymakers should adopt. 1. Are staffing hours per patient rising, flat, or falling after consolidation? 2. Did prices to patients or payers drop, stay flat, or climb relative to peers? 3. Did owners add leverage or pull dividends within 3 years? If hours fall, prices climb, and cash gets upstreamed early, you're not looking at efficiency, you're watching value shift away from care. If nothing changes, the consolidation path we're on leads to regional oligopolies with glossy quality dashboards and worsening bedside ratios. We've seen the preview. Next, we map where that road ends, and the off-ramp's worth taking.
The clock, melt, thresholds, and the wake-up. The climate curves don't shout, they lean. Year on year, basal melt thickens into a slope you can feel in your stomach. The geophysicist runs the coupled models that pour Antarctic freshwater into oceans and watches the maps change color where they shouldn't. Southern ocean cools, far north warms, currents twitch. He overlays the infrasound baseline across that century-scale ramp. The prime staircase doesn't flatten, it tilts, as if a careful hand is rebalancing while the table slips. They start speaking in thresholds. Not dates, thresholds. A gradient between ice and bed that used to hold now crosses a line more often. Pressure differentials that gave the machine fuel become erratic. In their shorthand, the temperature covenant phrase. The array hears it first. The constant offset, that signature lag from lunar maximum, drifts a hair and then returns with a new baseline. Adaptive mode, the analyst writes, hating and needing the phrase. The viewer's sentence, waking with the melt, gets reinterpreted as failsafe. Not awakening to greet us, awakening because the inputs went weird. A system designed to shepherd a volatile epoch towards stability doesn't nap through a storm. It stands up slowly and checks the knots. The microstory is a model run on a night that never happened yet. Perigee tide, anomalous warm pulse, harmonics step down into a narrower band. The geophysicist circles it. Failsafe corridor, constrained response. The team doesn't know if the real machine will do that. They do know the language allows it. Stakes turn blunt. Exposure isn't just optics, it's function. If retreating ice peels back the roof, apertures widen, coupling changes. The vent field was tuned to a load. Change the load, you change the instrument. We need to keep it covered without lying to ourselves, the team lead says. Treaty language can guard a coordinate. It can't slow a melt. The decision tree sits on one page with ink that smudges because hands keep going back. Publish anomaly to slow exploitation, invite public censors and risk panic, hoax claims, and the rival reframing it as theirs. Or classify deeper, protect the site through silence, and risk exactly the thing they fear. Someone stumbling into alignment because they didn't know to avoid threes. The case officer draws both branches and writes the same sentence under each. Unintended triad alignment is the coin toss we can't afford. Unknown to them, across town, a rival memo uses friendlier words and walks toward the same cliff. Calibrated acoustic probing, they call it, which is a clean phrase for a dirty idea. Pulse the vents until they sing back, then map the song. The liaison flags the timing, spring tides again, and nobody in the skiff smiles. The human moment arrives in a small, wasteful act. The case officer drafts a letter on thick paper he bought because permanence felt like armor. It's addressed to a person he'll never mail. The future oversight chair, the one who might inherit this if the ice drops too fast. He writes what can't go in a memo. You can't own a stabilizer you didn't build. You can only decide whether you act like kin or thieves. He signs it with a name that will never be attached to this file, and tucks it into a box with a map that doesn't look like a map. Publicly, the program shutters. It has to. Budgets cut neat stories. This one refuses neat. The press release is a paragraph about reprioritizing analytics. The array goes dark on paper and louder in reality. A black cell keeps listening, migrating stations when storms eat their flags, swapping IDs with weather buoys to keep from showing up in catalogs with names that get noticed. Years pass like a long tide. The grid on cork yellows at the edges. The viewer retreats from public life with the kind of silence that isn't sulking, it's maintenance. The handler retires into a house that smells like pine and lock oil and keeps a small metal box on a shelf behind dog-eared paperbacks. Not because he's hiding a treasure, because he's hiding responsibility from a world that loves souvenirs. And then the gut punch doesn't come from a model, it comes from orbit. After a summer of freak warmth and rain that shouldn't be rain, a satellite pass over the dome sends down a slice that makes the analyst stand too fast. Under a new lens of meltwater, a line shows, sharp, laser straight, a few kilometers long, oriented at exactly 60 degrees to the old flow. Natural ice draws straight only when it wants to lie. This line refuses to curve. The room compresses around it. The geophysicist tries to kill it first, processing artifact, speckle, a stitch in the mosaic. He reprocesses. It holds. The rival files a patent for a sensor that listens to bed pressure at tidal frequency and calls it a maritime tool. Oversight pretends not to see the line and sends a polite request for further characterization of subglacial seismic coupling. Translation: we believe you, we don't want to say it out loud. They go back to sentences that have been waiting on the board. We listen first. We do not align. We raise the safe radius because the roof is thinner and the instrument is louder. They add one more. If the line is exposed again next season, we seed the blandest truth into public science. Prime encoded, tide-coupled infrasound exists, without coordinates. Anchoring reality before rumor digests it might be the only guardrail they can afford. The array hears the staircase flatten for 2 cycles, then reassert, new baseline again, as if a tuner tightened a string you can't see. The analyst doesn't write it's waking. He writes it's working. The viewer, standing in a doorway he doesn't step through anymore, says the quiet thing. If we make it shout, it will dampen us. If we keep listening, it might teach. They narrow the work until it fits inside vows. Observe. Decode. Protect the silence that keeps the ground from shouting. And every time the moon leans in and the vents whisper primes, they hear a clock that isn't counting down to drama. It's counting through thresholds, a machine older than their arguments, staying patient while they decide what kind of tenants they're going to be. Aftermath, silences and echoes. Public science trips over a shadow without seeing its shape. An aerogeophysics paper notes mysterious rectilinear subglacial reflectors beneath a high dome, attributes them to layering or processing quirks, and moves on. The figure sits there, angles too neat to be comfortable, wrapped in caveats thick enough to keep curiosity at bay. In the margins of a conference poster, a grad student circles 60-degree alignments and is told, kindly, to check for aliasing. Then a journalist opens an unmarked padded envelope on a kitchen table that still smells like last night's coffee. Inside, a thumb drive, a single printed coordinate block, 3 sketches in a hand that doesn't want to be remembered, and 1 word typed on a plain page: custodians. No cover letter. No pitch. Just a map that isn't a map and a noun that sounds like a job. He calls 3 sources. 1 hangs up. 1 says, wrong number. 1 says, don't print coordinates if you want to keep your passport. He files the drive in a drawer he never locks and doesn't sleep well for a week. Meanwhile, treaty talk gets tense in rooms designed to be dull. Delegations propose expanding scientific zones, where drilling is paused pending environmental review. No one says lattice or pressure language. Everyone knows this is about something more than penguin rookeries. A rival delegation pushes for broader flight corridors to support collaborative magnetics. Collaboration becomes a word with a wobble. The array keeps listening under borrowed names. A storm snaps a mast. A replacement appears with a weather station label and a serial number that points to a warehouse that never signed for it. The analyst checks the prime staircase like he's counting breaths. The geophysicist learns to love maintenance logs. The case officer pretends to retire and doesn't. The viewer vanishes from public life, not as a scandal, as a choice. A friend says he gardens in the mornings and reads tide tables like poetry. A rumor says he moved inland to stop hearing the moon. He doesn't return calls. He sends a postcard with no return address, a blank ring drawn in blue ink and 3 tiny marks darkened at every 3rd tick. The handler closes a door on a small office that smells like paper and lock oil, carries a shoebox home, and slides it behind dog-eared paperbacks. The box holds a letter that will never be mailed, a photocopy of a lattice grid, and a note to himself in a hand that's grown careful. Do not align the triad. He doesn't look at it often. He knows it by heart. Rivals shift attention in ways that show up as footnotes. A procurement line for lunar cycle acoustic calibration turns into a patent application for a maritime sensor. A drone crash near a coastal shelf becomes a quiet consulate conversation about insurance. A research station swaps out its generator and logs a strange improvement in microseismic cleanliness. The phrase makes 2 people in Langley stare at a wall. Stakes linger in the spaces nobody fills with certainty. Who decides guardianship over a machine that isn't ours, under a treaty designed for ice and birds? Is guardianship even ours to claim if the thing works better when left alone? The team keeps the doctrine small, observe, decode, protect the silence that does the work. Then a page appears where absence used to be. The missing note lands in the team lead's encrypted feed the way a coin lands on a table, flat, undeniable. The handwriting matches the hand beside gatekeepers. The sentence is simple, written once and underlined once. Do not align the triad, system assumes command input. He prints it once and tucks it in the shoebox behind the paperbacks, not to hide it from the world, to keep it from turning into a headline, before it finishes being a warning. The missing page, a warning in plain sight. The note is 9 words and a line that feels like a blade. Do not align the triad, system assumes command input. Same slanted hand that wrote gatekeepers, same ink weight, same habit of underlining once as if anything more would be melodrama. The team lead reads it, prints it once, and doesn't circulate the PDF. Paper narrows the blast radius. Translation isn't difficult, acceptance is. Triad alignment, frequency, temperature, geometry, isn't a key you hold, it's a state the system recognizes. Cross the threshold in sequence, and it stops being a passive thing you listen to. It reads your input as intention. It follows the logic built into its bones, not the logic you hope it has. Assumes command input, the analyst says aloud, trying the phrase on like a splinter. It means the diagnostic pathway the viewer described isn't a wiretap, it's a handshake. And the second you shake hands, you're in the conversation whether you meant to be or not. Payoff ripples backward and explains everything that felt like superstition turned into doctrine. The memo that hardened into observe only, no intrusion was never about optics, it was about thresholds. The clause that allowed non-invasive sensing of peripheral apertures always hit a cliff. Non-invasive until the triad listens and decides you're speaking. The geophysicist writes the clearest sentence he's written in months. Inadvertent alignment can be indistinguishable from intent. He underlines indistinguishable twice. The room absorbs it in quiet beats. The handler closes his eyes and hears again the line the viewer left on the table. Don't align the triad by accident. The way you hear a pilot say brace over static. The case officer, who hates poetry, feels the sentence turn weight into policy. No more diagnostic fantasies, no field coils on tripods, no microthermal plates even in lab mock-ups. The rule becomes air, listen first, do not align. Emotion lands where bravado used to live. They didn't find aliens. They found responsibility. A planetary machine with a language tied to tides does not need humans to finish it. It needs humans to not confuse curiosity with control. The viewer's custodians, smaller, transient, cautious, look less like a species and more like a posture. Caretaker is behavior, not biology. The analyst circles a word he's avoided, stewardship. What nobody knew at the time is who wrote the warning. The handwriting matches the margin beside gatekeepers, the provenance doesn't. If it came from inside, someone old enough to remember when caution was a living memory decided to leave a sign. If it came from outside, then a rival with access to the same file decided they'd rather we didn't push our luck. Either way, the message fits the machine they think they've met, guardrails, not green lights. They test the note against their own procedures, hunting for damage. The passive array sits well outside any vent alignment. Its stations were placed to avoid constructive interference. Its microphones take what the moon gives. Magnetometer sweeps from the air, flown at constant speed, read fields without stroking them. The kill switches in their protocol, pre-committed thresholds that trigger shutdown, feel less like paranoia and more like competence. They add a new threshold. Any move toward triad closure, even in simulation, triggers a stop. The warning clarifies the rival's temptation. Calibrated acoustic probing sounds safe until it stacks frequency, heat, and geometry across 3 apertures. A tone here, a thermal drift there, a coil pointed just so, and the system hears a sentence. Oversight reads the note and finally understands why the team keeps turning down money-shaped offers to accelerate characterization. Acceleration is the wrong verb for machines that outlive civilizations. Meanwhile, something else was happening, quiet and useful. The array's long log shows one brief interval where the prime encoded timing bent toward a pattern that looked like a query. Harmonics tightened, the offset slid, then returned. The geophysicist and the analyst argued whether it was weather or instrument. With the warning in hand, they mark it a courtesy. The system nudged a dial, saw nothing aligned, let it go. The missing page doesn't make the machine friendly. It frames it as careful. A micro-story from an office no one remembers chooses that afternoon to surface. A technician years ago tested a vent probe on a bench with a coil and a heater. The power flickered in the building, one oscillation down at the mains, nothing any electrician would blame on Antarctica. He wrote it off. The note reaches back and turns that shrug into a wince. They archive the anecdote under a new label, near miss bench. They add a line to the lab door, no triad experiments in-house, no exceptions. The doctrine that had felt like superstition turns into engineering. They write a one-page field manual in language any crew could understand. Don't stack 3 kinds of alignment within one lunar cycle at any perimeter. Don't introduce heat at vents. Don't orient coils to the grid's angles. Never synchronize tones to spring tide. If you can't explain your setup to a stranger without drawing triangles, you're too close. The final paragraph writes itself. We didn't discover a city to conquer. We inherited a lease. Our job isn't to open doors. It's to keep from ringing a bell that was built to answer tectonic storms, not human curiosity. The case officer folds the page and tucks it behind the memo with the clause that made engineers sweat. He looks at the viewer, who looks at the floor that's always warm, and says the only sentence that sounds right. We can be custodians if we choose to be, and we acknowledge the official record's skepticism while we let instruments, not belief, lead. The transition back to where they began feels earned. The cold opens coordinates, the alarm in the control room, the panic that was really acceleration. Those moments were the sound of humans bumping against a language older than their metals. The missing page doesn't close the story. It reframes it. The coordinates still matter. The lattice still hums with primes. The moon still leans in, and the vents reply in pressure. But now the rule is written in ink and underlined once. Do not align the triad. Listen first. Learn enough to recognize distress. Then have the discipline to keep your hands in your pockets. Beneath the ice sits a machine older than our languages, asking for restraint more than discovery, and forcing us to decide what kind of tenants we'll be. If you want the declassified pages, the coordinate blocks, and the math behind the pressure language, subscribe and watch our follow-up on the Antarctic treaty fight and the rivals' quiet flights. Share this with a friend who still thinks the answer is to drill.